Morning, everyone. Happy third day of summer, and welcome to our last ground rounds of the year. And thanks in advance to the three division presenters that are going to round us out this year. I'm looking forward to these presentations. We are going to start with Dr. Jay Kim, Nephrology Fellow, and I'll turn it over to you.
Hi, my name is Jay Kim, first-year fellow, and my topic is on a prophylaxis checklist for immunosuppression. And I approach this as a practical, clinical-driven topic in something I'm weak in, but interested in learning more about. And notice that this is a checklist, not a guideline. We always have to tailor the treatment to the patients in front of us. We'll be going over patient-centered considerations, including some factors to consider when starting immunosuppression, screening for latent infections, and the steroid dose and duration to trigger that screen, some vaccinations and medication considerations, including the selected ones listed here. And note that I deferred going into transplant topic as I can't fit a whole year into this 25 minutes. So immunosuppression hygiene, let's go. Patient-related factors associated with increased infection risk, age greater than 65 and poor functional status, medical history, pre-existing comorbidities, including IV drug use, cancer, chronic lung, liver, kidney disease, asplenia, HIV, current infection, immunodeficiencies, and even socioeconomic status. Can they travel and make it to the appointments? Do they have enough caregiver support, or do they have cognitive impairment? Now, some of these might even determine whether or not we get the biopsy in the first place. And the consideration of these factors seem to be universal on all three sites. So good job, guys. Latent infections. Are they already clinically infected? Since steroids have a wide range in dosing and duration, when is the right time to screen? The data shows us in patients treated with 6 months of steroids, there's a 2.8-fold increase for doses less than 15 prednisone equivalents, and 7.7-fold risk for doses greater than or equal to 15 prednisone equivalents. So the cutoff recommendation was glucocorticoid dose greater than 10 milligrams for 4 weeks, and use of any other immunosuppression mentioned in this talk warrants a screen regardless of dose and duration, and screen for individual risk as well by asking about exposure to TB endemic areas and situations. Varicella. Some risk factors include advanced age at 60, corticosteroid use greater than 7.5 to 10 milligrams of prednisone equivalent, or having recurrent shingles history. There's no evidence for use of antivirals outside of the transplant literature, but you may consider a 400 milligram POA cyclovir daily in patients who have recurrent shingles. And we'll talk about vaccines later. Strongyloides. All right, I'm calling us all out on this one because I've never seen any of us screen for this. Mortality is up to 90% according to CDC in severe infections, and the true latent prevalence is thought to be underreported given mostly mild clinical manifestations such as pruritus ani. So I dug into this one a bit further. It can be found in subtropical and tropical regions, and prevalence may exceed 30 to 70% CPRS. Strongyloides infection is found more frequently in the socioeconomically disadvantaged and in institutionalized populations and in rural areas, and people who may have to deal with human waste. It's often associated with agricultural activities and poor sanitation as well. And in the US, strongyloides larvae are found in the soil in the southeastern states and the Appalachian regions. We should be screening for immigrants, refugees, travelers, suspected exposure to being barefoot outdoors even, and military personnel. And that barefoot thing is because the way this works, it digs into your feet or any skin areas exposed to soil, climbs up through your venous system, right side of the heart, lungs, you cough it up, you swallow it, and that's where it starts the auto-infection cycle. And you can get hyperinfection and disseminated infection in immunosuppression, and hyperinfection is where there's accelerated auto-infection, where there's intestinal obstruction, GI bleed, ileus, perianal skin manifestations, where the replication is just overwhelming the immune response, or disseminated, where it breaks out of its typical life cycle and causes things like meningitis. Exposure to endemic areas or tourism, and a systemic review of disseminated and hyperinfection cases of 244 patients showed that 163 of them were on corticosteroids with a mortality rate of 62.7%. And there's no data on the dosage of steroids that should even trigger this hyperinfection or dissemination. So there is a preemptive strategy and a reactive strategy. The preemptive strategy being doing serologic testing and administering empiric treatment for high-risk individuals while the tests are pending, or the reactive strategy for patients who require immunosuppression. They might not need to begin the treatment promptly. You can perform the serologic testing and administer the treatment if it turns out to be positive. And it's ivermectin 200 micrograms per kilogram daily for 2 days and repeated in 2 weeks. So it kills 2 generations of the strongyloides. And it's generally well tolerated. Hep B, the steroid dosing that's considered high risk for reactivation is 20 prednisone equivalents for 4 weeks or 10 to 20 prednisone equivalents for 8 weeks. We should screen for patients in the higher risk steroid dosing category or prior to starting any other immunosuppressants. Patients who have a positive core and a positive surface have a high risk indicated in red here, and positive core and a negative surface have a moderate risk indicated in orange here, 1 to 10% risk. Patients with high risk require antiviral prophylaxis. Rituximab use requires antiviral prophylaxis for the moderate risk group. And for patients in the moderate risk group, there's 2 options available, the reactive or the routine prophylactic antiviral treatment, where you monitor serial Hep B DNAs and administer accordingly. And I have seen you guys do this portion, so good job, guys. Entecavir or tenofovir is the preferred agent because of the low risk of resistance. All right, we should also screen for Hep C with reflex RNA, HIV, sick contacts, recent travel, pets, pregnancy in women of childbearing age, perform a thorough skin and teeth exam, and update cancer screening. All right, moving on to vaccines. A 52-year-old woman with diabetes and well-controlled hypertension is presenting to the office with worsening hypertension with labs showing anemia, thrombocytopenia, schistocytes, 2+ proteinuria, 1+ hematuria, and a subacute AKI. You decide to schedule for biopsy. You send for serologies. Your highest differential is a TMA. Her annual flu and childhood vaccines, Shingrix, and Tdap are all up to date. What should be done in terms of additional vaccination? And I'm going to present 2 very simplified scenarios. Wait until after biopsy and make immunosuppression decision prior to vaccine decision, or give some of these vaccines now, PCV20, Hib, MenB, and MenACWY. All right. So in scenario A, we're scheduling for a biopsy. You get the biopsy and you get the path result. It confirms your suspicion of a TMA, and you decide to vaccinate all those encapsulated organisms while we're waiting on the prior auth for eculizumab. Whereas in scenario B, you schedule for a biopsy with the TMA already in your mind, and you decide to send them for all these vaccinations. Get the biopsy, path result confirms your diagnosis, your suspicion of TMA, and notice how in scenario B, it allows a greater lead time before administering the eculizumab. We put a lot of thought into whether someone should be biopsied or not. We should think one more step ahead and think about what vaccines they might need. The patients who need the vaccines the most are also the patients who are unable to mount the adaptive response. And I know this is an oversimplified scenario. Real life of TMAs involve steroids or Plex or ADAMTS13, but I hope I made the point in reviewing the vaccine schedule early is what's important. Yes. All right, complicated chart. Just focus on the red here. Within this immunocompromised category, since the other ones are standard of care, we're going to focus in on zoster, pneumococcal, meningitis, and Hib. MenACWY and MenB. The initial dose is a part of our regular vaccine schedule at 16 to 23 years old. And it's indicated, again, for patients who are going to receive a complement inhibitor. And rules for both vaccines are the same. They need regular boosters for increased risk, including administration of eculizumab, administer a booster 1 year after the initial dose and every 2 to 3 years thereafter. Hib, it's indicated in patients who are getting complement inhibitors or who have asplenia. Pretty simple for that one. Did you guys know that there's PCV 15 and 23 on top of the PCV 13 and PPSV 23? So patients who are 65 years old, they should be already getting this, but our 19 to 64-year-old populations with CKD or immunosuppression, the same rules apply for both populations. And you could go through this diagram, kind of simplified it. Classic 13 and 23 stands, PCV 20, 20, 20. That completes the vaccine series. And if they've been given 15, give 23. Zoster, immunosuppression, it is recommended for all ages greater than 50 years old, and for those who are immunosuppressed, administer the vaccine off-label if indicated, if they have a history of shingles or chickenpox. And for patients who don't remember, that's a shared decision-making there. And Zostavax is outdated, so administer the Shingrix 2 months apart from that if they've had the Zostavax before. Therapy-related factors. We're going into the meds now. Talking about regimen chosen, we need to think about the regimen that's being chosen, the length of treatment, the drug safety profile, patient's response to the drug, and long-term efficacy of the treatment. And 3 key immunosuppressive mechanisms of glucocorticoids include impaired opsonization and phagocytosis, increasing the risk of bacterial infections, impaired T-cell migration and proliferation, increasing risk of viral, fungal, and mycobacterial infections, and impaired eosinophilic proliferation and apoptosis, increasing risk of parasitic infections too. All right, PGP prophylaxis, the risk is higher and it's indicated in patients getting 30 milligrams prednisone equivalents for 4 weeks, 15 to 30 for 8 weeks, a combination of 15 to 30 and cyclophosphamide, or greater than 10 and 2 of the following, either advanced age, coexisting lung disease, or use of immunotherapeutics. First line is Bactrim, either single strength daily or double strength 3 times a week. If there's intolerance or if there's a contraindication, alternative therapies are Dapsone. Remember to check for G6PD. And if G6PD is deficient, you can go to atopiquone or once monthly nebulized pentamidine. And for patients in this category D here, prophylaxis should be continued until the corticosteroid dose is less than 5 prednisone equivalents daily. Moving on to non-infectious complications. GI prophylaxis. Corticosteroids increase the risk of gastrointestinal bleeding or perforation by 40%. And use a PPI or H2 blocker when the dose is greater than 5 milligrams per day for greater than 2 weeks. ACR put out an updated guideline in 2022. I won't go too deep into it, it's a lot. But they're basically recommending FRAX scoring on initiation if greater than 2.5 milligrams prednisone equivalent for 3 months to stratify between low, moderate, or high risk. And performing bone mineral density testing within 6 months of starting glucocorticoids and 1 to 2 years while continuing. And they have a strong recommendation for giving bisphosphonates for patients in the high risk category who are greater than 40 years old, and it should be avoided in EGFR less than 35. Now, I was surprised about this one. Calcium, vitamin D, and lifestyle modification, they mentioned specifically, has low certainty of evidence. For avascular necrosis, it's postulated to be thought to be from fat hypertrophy, fat emboli, and intravascular coagulation that impedes the blood supply to the bone. And cumulative dose is the most important determining factor, typically happening between 2 to 3 years, and there's no consensus on screening. And early identification is the key to treatment, performing an MRI or bone scan, and ask the patients to avoid high-intensity thumping type activities. So my practice point would be document areas of high pain or pain prior to starting the steroids and have a high index of suspicion for insidious onset of pain at typical sites, including the femoral head. It can also occur in the knee, shoulder, ankle, and hand. Adrenal suppression, it's mostly subclinical, and risk is minimal if duration is less than 3 weeks. And this is where that taper guideline comes from. And you might see symptoms of nonspecific fatigue, lethargy, anorexia, weight loss, nausea, vomiting. Or it can be severe, like an adrenal crisis where you have hypotension and tachycardia, which may be life-threatening. Stress dose steroids, they may be needed in times of major infection, trauma, or surgery for adrenal crisis. And workup and management is very complex, so recognition of this is key. Antimetabolites. Some general considerations include it is an anti-proliferative agent inhibiting purine synthesis in both B and T lymphocytes. It's protein bound and levels might be increased in hypoalbuminemia, like in our patients. There's decreased absorption with antacids, phosphate binders, and PPIs. And trough levels may be obtained to guide therapy in cytopenias or in GI upset. It's contraindicated in pregnancy. Get a pregnancy test. Excuse me. And nausea and diarrhea are the most common side effects, and MPA may be better tolerated than MMF. Some recognized infectious associations include JC virus, CMV, and VZV, and there are reported cases of these organisms here. For prevention, early recognition of nuanced and neurologic symptoms was heavily emphasized, including hemiparesis, apathy, cognitive deficiencies, blurry loss of vision, hearing loss or ear pain. These would be from VZV. And we need immediate brain imaging with neurology consultation with ID involvement, depending on the results. And also highlighting the need for VZV immunizations in patients who are getting mycophenolate. CNIs, it inhibits signal 3 of this T cell activation, and it also has a direct actin cytoskeleton stabilizing effect on the podocyte. Most of the literature surrounding risk of infection revolves around the transplant setting, so I won't go too much into that. But it has a narrow therapeutic range. It can impair your fasting glucose, cause hypertension, hyperlipidemia, and the levels are highly variable according to whatever medications might be affecting your CYP3A4 or with even diarrhea. There's the cosmetic concern with tacrolimus that may cause gum hypertrophy or alopecia, and nephrotoxicity and hyperkalemia as well. Cyclophosphamide, it is a prodrug that metabolizes into phosphoramide, mustard, and acrolein. And the infection risk includes neutropenia, reactivation of any latent infections, and which is more common if there's a concomitant steroid use. You can get skin cancer, myeloid malignancies, and bladder cancer with high cumulative doses. But note that all our current cyclophosphamide protocols for lupus nephritis, membranous, minimal change, and vasculitis have a cumulative dose of less than 20 grams. Hemorrhagic cystitis can also occur. You can get gross hematuria due to the acrolein, and Mesna binds acrolein, but its efficacy has been questioned in various articles. Hyperhydration has been mentioned to expunge out the acrolein and minimizing the contact time to the bladder. And it can also decrease fertility in both men and women with cumulative drug exposure. And it's at a lower dose than the cancer exposure at 10 to 15 grams, and which gets worse with increasing age. Rituximab, monoclonal antibody to CD20 depleting circulating B cells, but not plasma cells that are already formed. Duration of action is 3 to 6 months, and B cells may be depleted for 6 to 12 months. You might see some infusion reactions, and you can pre-treat that with Tylenol, Benadryl, or methylpred, and slow infusion rate to start. Post-treatment hypogammaglobulinemia, it's thought to be underreported because there's no routine pre-screening and no consensus on defining the cutoff for hypogammaglobulinemia. And the prevalence seemed to be variable 6 to 32% depending on the reviews. Infection complications. Whether you use it in a lymphoma or rheumatic disease, the infection risk varied from 31 to 43%. And there's no general recommendations to prophylax for rituximab. And you'll be unresponsive to vaccine for about 6 months after administration. And recall back to our hepatitis B. You do want to prophylax for the latent hepatitis B, or if they're moderate risk. Eculizumab, monoclonal antibody against C5, preventing the MAC formation. It has 1,000 to 2,000 times greater risk of invasive meningococcus. It's well tolerated. Infusion reactions are rare. And it increases your risk of infections with encapsulated organisms. And ideally, all recipients should receive the MEN-B, MEN-ACWY at least 2 weeks prior to initiating. And vaccine alone may not be sufficient to prevent an infection. And prophylaxis with penicillin or ciprofloxacin for the first 4 weeks was recommended by current opinions of infectious disease. But other sources are recommending that prophylaxis should be administered during the entire duration of the eculizumab. So my approach is going to be 4 weeks if they've had enough lead time for vaccination, and antibiotics for duration of therapy for those who have not. Takeaway points. At the time of biopsy consideration prior to the procedure, consider their vaccine schedule. Real life is going to be messy, but just even thinking about it might really benefit them. FRAX score and document areas of chronic pain when starting steroids. Get a pregnancy test for all women of childbearing age prior to biopsy. Test for latent infections and apply prophylactic measures involving appropriate consults when necessary. And immunosuppression, colonization, and infection are all on a spectrum, and we always need to individualize our treatment to the patient in front of us. And it's our duty to know and understand the meds we prescribe that the patients take with full trust, often without even any symptoms, and us just telling them, hey, you need to take this to save your kidneys. And immunosuppression is complex, and it's not benign at all. So the least we can do is keep a checklist to prevent complications. I'd like to acknowledge Dr. Jefferson, whose reference was studied throughout my presentation. I'd highly recommend going to see Jason reading Complications of Immunosuppression in Glomerular Disease, and Abal, my brilliant clinical mentor, who reviewed and provided a list of feedback for me. So thank you, guys.
Thanks so much, Dr. Kim. Questions? Well, I think we're all impressed with the breadth. You know,
I have a question, Kate.
Oh, yeah, go ahead, Leah.
Jay, that was a wonderful and encyclopedic review, and I definitely learned some important pearls. I was just wondering how much of these recommendations are center specific, because my understanding is that different transplant centers have different protocols, and is there some place where they're all together, the best ones, the recommended ones, that I can look up when I'm trying to figure out what to do?
Yeah.
I have a copy of your slides too, so.
Yeah. So I basically compiled this borrowing data from our rheumatologic and our hematology and Dr. Jefferson. And this is basically a review of reviews. I didn't go too much into the primary literature, I must admit. So I can definitely give you the reviews that I use to go into this.
Sure.
there's clearly there's a lot to think about as you're pointing out. And, this is in the context of already a complex decision-making for the patient and things. You talk about kind of moving your thought process forward in terms of when you're thinking about this. How do you introduce this kind of these considerations with your patients? How do you fit that in with your usual conversation about?
How do I fit that in?
Yep.
I think I've only immunosuppressed like 2 or 3 people. And I mean, I continue, maybe a ball and Dr. Jefferson can talk about, or people who are more,
Fair enough.
More experienced.
It's usually messy, and you just are trying to catch up and individualize to the patient. So it's not clear cut as stated.
Yeah, I think half the battle is stepping back and thinking about it. We spend, I think, 90% of our brain power trying to decide on the actual immunosuppression itself. And I think you just need to step back and spend a little bit more on exactly what Jay is talking about. How do we protect our patients when they get immunosuppression? So, I kind of have a checklist that I go through whenever I see a patient and immunosuppress them in a very similar way to this.
Well, thank you again, Dr. Kim. Comprehensive talk.